Hello again, my name is Dr. Ukiri Richard. I am giving you the podcast on basic cardiology. Today we are going to talk about reduced exercise tolerance. I'm using a 36-year-old female patient that presented to your cardiology clinic as the presentation. This girl usually jogs 1 to 2 times a week and has been noticing gradually reducing tolerance for the past 6 months. She sometimes feels tired. She did a blood test with her house doctor that did not show any pathologic findings. In her family, there is no cardiovascular heart disease, and until now she has been healthy. In the physical examination, you notice in sitting position 2/6 systolic murmur in the second intercostal space right, as well as a fixed splitting of the second heart tone. ECG showed an incomplete right bundle branch block. What is your suspected diagnosis? Well, the history, the examination finding, and ECG are in keeping with my suspected diagnosis of an atrial septal defect. Through a shunt at the atrial level, it has resulted to a right heart overload, which can cause the symptoms she is presenting with. Due to the raised left ventricular volume and the prolonged ejection phase, we usually see accelerated flow across the pulmonary valve, so as well as a respiratory dependent splitting of the second heart tone. An incomplete right bundle branch block can be seen in young patients as a physiologic finding, but can also be seen as a sign of a right heart overload. Okay, good. What are the types of ASD that you know? Anatomically, according to the occurrence, we have 4 types of ASD, which is the ASD secundum type, ASD primum type, ASD sinus venosus type, and ASV coronary sinus type. The ASV secundum type, which is the most common type, occurs in 75 to 80% of patients, and it is usually in the area of the foramen ovalis, fossa ovalis. The ASB primum type, which is inferior, occurs in 15 to 20% of cases and is usually near the crus cortex. The third common type is the ASD sinus venosus type, which is actually near the entrance of the superior or inferior vena cava, which is 5 to 10. Then the very rare one is the ASD of the coronary sinus type, which is less than 1%. Well, it is not uncommon to see in cases of ASD of secundum type, that means ASD in the region of the foramen ovalis, fossa ovalis, that you have coexisting multiple small atrial septal defects, which is also called multifenestrated ASD. An ASD of the primum type, that is in close to the crus cordis, is usually in most cases a defect of the atrioventricular defect, means splitting of the anterior mitral valve leaflet. That means the ASD of the ASD primum type is in most cases an atrioventricular defect and causes or is usually associated with splitting of the anterior mitral valve leaflet. In ASD of the sinus venosus type, you usually see a partial anomaly in which there is a wrong origin of the right pulmonary vein in the right atrium. A persistent foramen ovalis, that is PFO, is usually a short connection between the both atria, which does not belong to any of the above named anatomical types of ASD. But let me add that sometimes you see form of symptom defects in association with chromosomal or genetic syndromes like Down syndrome, Noonan syndrome, Holt-Oram syndrome. So my question is, what symptoms do this patient present with? Well, some patients remain symptom-free even up till adult age, so that ASD may be overseen, because even here the typical auscultatory findings may be missed or are not present. In its adulthood, the most common presentations are exertional dyspnea, palpitation, tiredness, and recurrent pulmonary infections. Also, you could have paradox embolism when you have PFO. In advanced stages, it is not uncommon to have heart rhythm disturbance arrhythmias like atrial flutter, atrial fibrillation, and sinus node syndromes. Large atrial septal defect will cause, when not treated, to a pulmonary hypertension through elevation of pulmonary vascular resistance and resulting usually therapy-resistant symptoms. Small ASD less than 1 centimeter could remain for a long time unnoticed, but as you get older, because of the reduced compliance of the left ventricle and the resulting greater shunt volume, become clinically relevant. Good. My next question now is, how do you determine where the indication to do an invasive therapy? Well, the following indications are sure indicative for an invasive therapy. 1. When you have signs of right cardiac volume overload, that is dilated right heart chambers, independent of the symptomatic. This is class 1 evidence B. 2. If you have pulmonary blood flow or systemic blood flow, if you have the quotient of the pulmonary blood flow to the systemic blood flow more than 1.5 in the right heart catheter examination. 3. If you have the pulmonary artery pressure less than 22.3 to 2/3 of the systemic arterial pressure, when you have the pulmonary vascular resistance less than 2/3 of the systemic vascular resistance, or when you see improvement from a pulmonary vasodilator or a trial occlusion. 4. Occluder system is the therapy of choice in ASD of secundum type when it can be applied. 5. When you have paradox embolization. 6. When you have a documented orthodeoxystroblastic, which is fall of oxygen saturation in relation to body position. And 7. An ASD occlusion should not be done in patients with Eisenmenger syndrome. So my next question is, now what options or what choices do you have in terms of doing the closure of the ASD? Well, the choices we have are either an operation or a catheter guided shield implantation, sham implantation. The operative ASD closure usually uses either a patch plastic or a direct sewing occlusion through a right-sided thoracotomy, stenotomy, or a new mini thoracotomy method. Any other anomaly should be corrected during the procedure. For example, correction of any malformation or a wrong pulmonary vein origination, tricuspid valve repair, or Mace procedure in case you have atrial fibrillation and atrial flutter. As long as you don't have an existing pulmonary hypertension or any serious comorbidity, the perioperative mortality is usually low, less than 1%. The long-term outcome is usually very good and usually lead to either a very significantly improved symptom or even complete cessation of the symptoms. In the catheter-assisted shield implantation, through the femoral vein or inferior vena cava, the right atrium can be assessed, and with the assistance of a transesophageal echocardiography, ADA, or an intracardial ultrasound with fluoroscopy control in left atrium position. The defect can be measured with a balloon, that is the stretch diameter. Don't forget that the sheath has a double leaflet, one in the left atrium and the other one in the right atrium. The left atrium shield will be released and placed on the interatrial septum, which actually should be able to cover the defect. Thereafter, the right atrial shield will be released. But in intervals, a lot of systems have been developed for this ASD occlusion. It is worthy of note that any patient that can have the ASD occlusion between the 25th year of life will have a normal life expectation. My next question now is, which ASD should or must be operated on? Well, ASD primum, sinus venosus, and coronary sinus should be operated on, and also with patients that have a cardiac anomaly that needs operative correction. Also, patients with ASD from secundum type that have contraindication to percutaneous intervention, for example, when there are no enough septum tissue in the anterior and posterior defect borders. Also, in ASD secundum, in patients that also have a tricuspid valve operation, necessity for a tricuspid valve operation, they still require an operation. Now let's return back again. Which ASD types should be occluded interventionally, that is non-operatively? Well, anatomically uncomplicated ASD from secundum type should be occluded through intervention methods. But the requirement is that the defect diameter should be less than 38 millimeters during the balloon measurement, and it should have a border of more than 5 millimeters. The exception here is the aortal defect border. The peri and post-intervention complication here are very, very low. Serious complication is less than 1%. Even multiple ASD can be occluded in the same sitting as long as they have more than 7 millimeter separation. If you have two defects that lie closely in the same proximity, that is less than 7 millimeters, you can even use one occlusion system to cover both defects. Okay, that's good. My next question is, what primary examination do you need to carry out in this female patient? Or what morphological criteria do you need to evaluate the occlusion of this defect? Well, if you have patient with borderline indication, for example, patient with small ASD, patient with borderline dilated right heart chamber, or patient with discrepancy between the symptoms and the finding in the test, it may be wise to do a stress test. In patients with pulmonary hypertension, these tests may also help to document the changes in oxygen saturation. Number 2, the transesophageal echocardiography is a primary diagnostic modality to evaluate an interatrial shunting through the color Doppler mode and also a right ventricular volume overload. The whole septum has to be examined from the superior onto the inferior vena cava. To judge the right heart overload, you have to measure the right heart chambers. Other parameters or indices are paradox movement of the interventricular septum with diastolic flattening, as well as measurement or estimation of the left ventricular pressure through the systolic maximum flow across the tricuspid regurgitation jet. Number 3, to get an exact judgment of the size of the defect and the morphologic structure of the surrounding tissue, as well as to know the place to insert the shield, and also to know the origin of all pulmonary vein, it's wise to do a transesophageal echocardiography in 3-dimensional mode. For an exact judgment of the size of the defect and the morphology, and the surrounding structure, as well as insertion of the pulmonary vein. To know those things, the three-dimensional TEE should be wise. But in complex ASD, like AVSD or coronary sinus defect, with associated intracardial anomaly, especially when you have valvular problems, or, for example, if you need to measure the PFO tunnel, the TEE also helps to give a definite information. Well, lastly, the cardiac MRI, gives you a detailed information about the cardiac anatomy, and also in the calculation of the right ventricular function and the shunt volume. But this is recommended only in cases where you have bad visual possibilities with ultrasounds, irrelevant of which means you choose, which visualization modality you choose. An exact measurement of the defect and the surrounding structure must be known. We must know the maximum defect diameter, as well as the anterior and posterior septum wall, measured in different axes. Don't forget that a requirement for interventional treatment of ASD, the diameter must be less than 38 to 40 millimeters of mercury and must have enough distance, more than 5 millimeters, from all free atrial wall and AV valves. Good. My next question is, do you need to do a coronary angiography or heart catheterization before this ASD occlusion? Is it necessary? No. Only in patients where, depending on their age, they may have a coronary heart disease, or in patients without sufficient non-invasive diagnosis should have a heart catheterization. Oh boy. Finish. Oh boy. Well, patients with defect less than 5 millimeters without symptoms and signs of right heart overload don't normally need a defect occlusion because of the benign spontaneous progression. Also, patients with severe irreversible pulmonary artery hypertension without evidence of left-right shunting, that is pressure balance, shouldn't get an ASD occlusion and should be managed conservatively with medicaments. But I will let you know some special contraindication to percutaneous defect occlusion. 1. Patients that have congenital or acquired cardiac anomaly that require surgical correction. 2. Patient with sepsis within 1 month before the operation, or patient with active systemic infection. 3. Patients with tendency to bleeding, gastrointestinal ulceration, or under contraindication against a 4-month antithrombocytic therapy. 5. Patient with intercardial thrombus. 6. Patient in which the defect wall are less than 5 millimeters from an AV valve, the coronary sinus, or the pulmonary vein. 6. Patients that have nickel allergy. And 7. Patients that have contraindication to the carrying out of a transesophageal echocardiography, like esophageal stenosis, esophageal diverticulosis, or that have contraindication to catheterization, cardiac catheterization, like complicated vascular access. So that's good. My next question is now, what complication could come up during or after the intervention shield occlusion of the ASD? You can have a rest shunt due to inappropriate shunt occlusion. You can have an occluder embolization or air embolization. You can have an occluder fracture. You can have pericardial effusion or tamponade, myocardial rupture, or dissection. You can have erosion of the atrial wall or aortic root through the occluder. You could have occluder malpositioning. You could also have hindrance or influence of the neighboring structures like AV valve or pulmonary valve. You could have hemolysis, occluder thrombosis, thrombus embolization. You could have endocarditis in the first 6 months. You could have arrhythmia or depolarization disturbances. And what complication can occur during or after an operative ASV occlusion? Well, in that case, you could also have a pericardial effusion or tamponade. You could also have a rest shunt. You could also have a right ventricular systolic or diastolic dysfunction, mitral or tricuspid insufficiency, and arrhythmia, pulmonary vein stenosis or vena cava stenosis, which is also a sinus venosus defect, or you could also have a post-pericardotomy syndrome, which is what we call the Dressler syndrome, which is a combination of pericardial effusion and pleural effusion. So now let's come back to this, our patient. What treatment will you suggest? Well, after looking at all the findings, the age, the symptom, the right heart overload, intracardial anomaly, I think in this there's no indication, and without any other contraindication, I will suggest a catheter guided occluder implantation. Thank you very much. So after the occluder implantation, what do you watch out for? Well, 6 months after the occluder implantation, you have to take aspirin. Well, usually you add clopidogrel to aspirin, in which case thereafter the endothelialization of the occluder will be completed. 2, you have to do a regular cardiologic checkup, including evaluating for rest shunt, documenting the size of the right ventricle and right atrium, as well as tricuspid regurgitation and pulmonary artery pressure in echocardiography. We do ECG, if possible ECG Holter, to check out for arrhythmias. Additionally, don't forget that the typical check if you don't have rest shunt or other complications is 4 weeks, 6 months, 12 months, then 2 to 4 years. Typical late complications are atrial tachycardia, arrhythmia. Don't forget that in these patients, a transeptal punction or ablation should never be done. It's not possible anymore. And endocarditis prophylaxis should be given within the first 6 months after implantation. There's no restriction to sport activities, especially by asymptomatic patients without pulmonary hypertension, arrhythmia, or right ventricular dysfunction. When the occluder is in situ, it is no contraindication for a future pregnancy, especially in asymptomatic patients. Then I really need to talk to the radiologist and the makers of the occluder to see the compatibility with MRI. Thank you very much.